Maximum Health with your host, Dr. Ken Gray. Dr. Gray obtained his master's in both acupuncture and Oriental medicine from the Atlantic Institute of Oriental Medicine. Dr. Gray enjoys both being a physician as well as being an educator. His unique approach to holistic healing has taken him abroad to lecture in Germany and treat sports professionals in Hawaii and France. He is co-author of several books on food therapy. His office is in Jupiter, Florida, where he has practiced for over a decade and where he resides. Now it's time for Maximum Health with Dr. Ken Gray.
In the ground we bury the seeds of a pantry, all the things we carry. Now we're down to our bare feet. May I have this dance to you? Can I say something crazy? I love you.
Welcome back, everyone. This is Maximum Health Radio, quality living with yours truly, Dr. Ken Gray, holistic physician. Thank you for joining us every Friday, 7 p.m. Eastern Standard, on 88.9 FM, WQCS, and that's NPR of the Treasure Coast. We're also available via Public Radio Exchange. That's prx.org. It's a wonderful free service, and it's available all over. If for some reason you need to walk around and listen to this or leave the house, you can put us on your phone, WQCS.org, and listen live. And as you know, every week we have special guests, a new one every week, and we try to focus on the best, we do a very good job of focusing on the best of health and well-being from all sectors of life and wellness. You've heard us talk about financial health, social health, environmental health, physical health of all sorts. Today I wanted to do a knee show, just because as a physician I've seen a lot more in the way of different approaches to knee health, restoration of knees. There's a shift in the paradigm of how we deal and view knees and how we should take care of knee injuries. And so I brought some authorities in for you. The MD in the house today is Evan Peck, Dr. Evan Peck, section of sports medicine, Department of Orthopedic Surgery, Cleveland Clinic, Florida. As you know, I'm a big fan of Cleveland Clinic and their patient-centered approach. I'm sure a lot of you out there are as well. We have some of my favorites, if not my favorites, in the game of physical therapy, rehabilitation, sports medicine in that area, is Elisa Fawcett and Holly Whitford from Sailor Physical Therapy. They've probably taken care of, over the years of experience together, a majority of the world, but if you're lucky, you found them, and you're better off for it. And so that's who we have today for you, and thank you for joining us. Again, if any part of this is missed, there's always prx.org and wqcs.org. This is Maximum Health, and we will start off with you, Dr. Evan Peck. Thank you for joining us.
Thank you so much for having me today. It's certainly an honor to be included on your show, and really look forward to talking about the knee. I see a lot of injured knees in my practice, and it's certainly an area of increased relevance as people not only age in this country, but physically active people age. So with the baby boomer generation, you have a generation that's very focused on remaining active as they get older. And so they're not going to sit and knit sweaters all the time. They're going to get out there and be active. And as they age and continue to want to remain active and participate in their desired activities, the knee is a common area that breaks down, whether it's a muscle or tendon injury, a ligament injury, or wear and tear on their cartilage. So this is a really relevant area for all of us, for everyone.
We've seen it put sports players out, poor Mr. Rose. It's so much high hopes for him with the Chicago Bulls. Saw that, his knee bend back, and everyone in the world just cried. I was one of those people. I mean, there's so many ideas of that. For me, I was out for years. Lisa can attest to that with my knee from jiu-jitsu injuries, running on it. I never had surgery, and I chose to rebuild it back different ways. Was that the best option? And it seems like there's new data that you don't always need surgery. What's the deal?
Well, certainly there's a lot of things that can go wrong with the knee. So it kind of depends on, of course, which injury, people have. Obviously, just kind of looking at it, you can categorize knee injuries into two broad categories of sort of acute injuries, things that happen all of a sudden while you're doing something, or chronic injuries where your knee starts to feel bad over a period of time gradually, and you notice that it's starting to interfere with your desired activities. I will tell you that in my practice, and I am not a surgeon, I certainly work with surgeons. We have a comprehensive department that has non-operative and operative physicians in the same department working together collaboratively. But in my practice, certainly the vast majority of both acute and chronic knee injuries don't require surgery. And in many cases, addressing the injury through a number of different non-operative means, including the involvement many times of an outstanding physical therapist, like the two excellent therapists we have sitting here today in the studio.
Standing applause.
Who see a ton of my patients and do a fantastic job. But many times, these injuries either occurred because of some physical deficiencies that could be corrected in therapy, or because of the injury, the patient lost some physical capability that can be regained through physical therapy. So I'm a strong believer in utilizing therapeutic exercise and therapeutic modalities to improve your function, decrease your pain, and return to your desired activities.
Yes. And I like to refer to this sort of approach as a tiered approach where you don't always jump for the big guns. You have all these different options and you choose the ones that's appropriate for your particular injury. So I like that you outlined that. I guess one thing I just want to, I remember working as a medical assistant at about 21, which dates me, I'm about 20, that's 20 years ago or more. And I was one of the biggest orthopedic firms, and they did a lot of arthroscopic surgeries where they make these small incisions and they go in and they cut away little debris of cartilage in the knee. They're saying that that's not so much the idea of where we can go now. Do you have patients, and I know you mentioned you're not a surgeon, so I don't want to get into the surgery aspect, but do you have situations where someone might come to you as a first step, and how do you decipher whether or not they need that surgery, and is it becoming less and less prevalent for people to sort of go after that type of minimally invasive, quick, in and out arthroscopic?
So arthroscopic surgery is a technique. It's not a specific procedure, but it can refer to a way of doing surgery on a number of different injuries. So, for example, you can use arthroscopic surgery to treat a meniscus tear. You can use arthroscopic surgery in part to reconstruct a ligament. One of the things that's really changed in the last 20 years with regard to arthroscopic surgery in the knee is that previously it was felt that if someone had some osteoarthritis in their knee, perhaps a degeneration of some of the cartilage in the knee, that they would benefit from an arthroscopic surgery, as you described, something that's minimally invasive, pretty quick recovery. Essentially, the alleged benefit would be that the surgeon could go into the knee with a minimally invasive approach, perhaps, quote unquote, clean up the cartilage, get out of there, let the patient return to activity relatively quickly. And the thought was that this would decrease arthritis symptoms and improve the patient's function without having to resort with a more extensive surgery like a knee replacement. However, there was a landmark study in the early 2000s put out by Dr. Mosley at Baylor College of Medicine in Houston, Texas, that was published and essentially showed that if you did arthroscopic surgery on people with knee osteoarthritis, those patients performed worse or did worse than patients who had a sham surgery. So in other words, if you just put the patient to sleep and made the arthroscopic incisions and then just woke them up and said, okay, your surgery's done, and that was the sham surgery, not only did the real surgery not do any better, the real surgery actually did worse. Those patients did worse, and they did so much worse that they had to stop the study because it was unethical to continue giving patients a treatment that was bad for them. So this was published about 15 years ago, and it really was a big paradigm shift in how we approach osteoarthritis surgically. And there's been a number of studies that have corroborated those findings in the last 10 to 15 years, to the point where at this juncture, performing an arthroscopic surgery for knee osteoarthritis really doesn't make sense. And that's pretty well accepted in the orthopedic surgical community, with a few exceptions, because sometimes old habits die hard. But certainly in our practice, we try to avoid arthroscopic surgery for arthritic knees. We know that essentially what we're doing is taking a problem where you've lost your cartilage and then the treatment is to make you lose more cartilage. And that doesn't really make sense.
Right.
On the other hand, some patients who have meniscus tears in the knee may benefit from arthroscopic surgery. In general, though, even with those patients, many of them do not need surgery. And we typically reserve arthroscopic surgery for meniscus tears for the patients who fail conservative treatment, including physical therapy, and for those patients who may have mechanical symptoms. So if a meniscus tear is causing your knee to lock up, to catch, to continuously swell, those patients often may require arthroscopic surgery to remove a piece of the meniscus that's causing those what we call mechanical symptoms. But if a meniscus tear is causing pain and no mechanical symptoms, in the majority of those cases, those patients can be treated without surgery, and we certainly have seen a lot of success with that. And I think the big point here is that by avoiding arthroscopic surgery in those patients, we're probably preserving their knee better for the long haul.
Yes.
So I think that's the important thing to think about with arthroscopic surgery. But of course, everybody's different. And so for anyone who's listening and may have knee pain, may have knee arthritis, may have a meniscus tear, it's important to discuss your individual case with your physician, because what I'm saying is very general, of course, and can't necessarily apply to everyone.
Right. And they should be able
uniformly.
to have it explained to them so precisely as you did. Everybody's unique, and so key is in the diagnostic process, and then the planning and giving options. And so some of those options obviously have been Lisa Fawcett and Holly Whitford we have here. Lisa, tell us a little bit about those cases which you've seen with Dr. Peck and others, which seem to pertain to what we're talking about, this shift in the approaches from instead of immediately going for surgery to really seeing a tremendous success with physical therapy and strengthening.
Sure. Thank you again for having us today.
Oh, it's amazing. Thank you.
I can definitely say that even in my short career early on, we saw a lot of arthritic knees with scopes to clean out a so-called worn and torn or torn meniscus, to second what Dr. Peck was saying. And they often did very poorly with even the attempt of returning to their prior level of function. And that now often we see much more success without the surgical approach, sometimes with different types of injections or medications, whether it be a synovial fluid replacement, acupuncture, prescription or not over-the-counter anti-inflammatories to help with pain and swelling, to partner with prescriptive exercise or progressive strengthening to support the knee and the muscles that support the knee, or act as shock absorbers so that not as much stress load is taken on the bones themselves. Right. So we have had a great success with just strictly conservative care, taking the person in front of us and deciding what level of activity they want to return to, and creating an exercise program that's specific to them.
It's amazing, and one of those things that you said is the muscles, and giving those, focusing on the strengthening so that it can take some of the work off of the bone joint situation, because as long as you don't have that muscle support, the bones is just right on the joints, just continuing to, all that force is just there. And I saw that because when I was in pain, I didn't use my leg as much, and it actually started to atrophy. Mm-hmm. And I didn't realize that till I went to go do a leg extension, a simple leg extension, which I could do many pounds. I couldn't even do 5 pounds.
Absolutely.
And people don't realize that because they just focus on pain, but the physical nature of pain relief in part has to do with keeping your strength level of your muscles intact. Sure. Yes?
There's definitely a delicate balance between what happens during the healing timeframes after an acute injury.
Yeah.
As Dr. Peck was saying, if something suddenly onsets and it presents with a sudden onset of swelling or pain, versus something that progressively builds over time, either or can create compensations in how someone moves, how they utilize their body. Like you said, you might have used your other leg a little bit more.
Whole lot more,
obviously. And it can create some significant disuse atrophy or wasting away or shrinking of the muscle size, girth, strength, and all of those things affect a further downward spiral of the joint health itself.
I know both of you deal with this, but Holly, how do you deal with a person that's been masking their problem for so long with, say, over-the-counters, and, they come to you and they're so used to maybe being on pain relief meds, and, I know I've shared patients with you where that's sort of the case.
Absolutely.
Yeah.
And it's a lot easier when, you actually have a conversation with the person, and especially if they're athletes or if they want to go, I have a lot of just older tennis players and other active older adults that want to return to their sport, but they don't realize they're doing more damage by just covering up the problem and not actually fixing the problem. Yeah. So that's when we get them, and a lot of the times you'll put them on the table and they can't even actively lift their leg properly with a good quad contraction, and they're out there trying to play tennis. So you could see why your knee would hurt, because you don't actually have the good support of the knee. Right. And a lot of the times they'll come in with knee pain and it's not even a knee problem. Right. It's more a hip problem, or their arches have fallen and they're altering their gait mechanics. And so we could kind of address the whole thing to actually fix the problem so that they don't need to take any kind of pain meds anymore, and then they're a lot happier in the long run when you actually fix the problem.
True story. And for some of you that may not know, the quad or quadricep is that front big muscle in the above the knee, sort of that atrophied in my case. That I couldn't lift, do a leg extension, simply straighten my leg. And then as far as your gait, that's really just the way you walk, right?
Correct.
Am I explaining that right for our listeners? And a lot of that shifts when we're in pain. And sometimes it can even stem from the spine. So not only the hip, but the spine. If you have scoliosis and you have a tendency to favor one end, and then you're very active. So activity-wise, do you usually tell people to, say, stop their activity?
Absolutely
say,
not.
like golfers and tennis players.
And
I mean, because that's got to be hard, right?
Either.
Because that's really, I think, and Dr. Peck, you may attest to this. The reason people want to pick the quickest method, which in their mind is surgery, fix it so I can get back to life, is because they think that if they do physical therapy, strengthening, all of those things, that it's going to not be a quick fix. And furthermore, it's going to take more of their time away from the things that they love. How do you, as a doctor, explain that?
So I think, there's a couple of things at work there. I mean, one is, what is the best treatment? And then the other one is, well, what will get me out there the fastest? I make sure that I let patients know pretty early on when I meet them that my goal is to allow them and to help them participate in the activities that they enjoy. I'm not one of these physicians, and I know there's many of them out there who say, well, you will never do X again. I don't say that in the vast majority of cases. My goal is to allow you to go do activity X again, but the problem is your body in its present state is often not physically prepared to do X, which is what Holly was alluding to. You have to be physically prepared, and so the way I explain it is you can't get in shape by playing your sport. You have to get in shape to play your sport. Now, the other thing at play here is the sort of, if I can overgeneralize a little bit, just sort of the American mentality of like, I want everything and I want it now. I want to get, ripped for the beach in 7 days or whatever. But the bottom line is that we all know through, not just in exercise and rehabilitation, but in all facets of life, the longer road and doing things the correct way in the long term will work much better. I do some regenerative medicine treatments in my practice, platelet-rich plasma and so on, and people sometimes will come to see me, and the first thing they ask about is that. And my response is, how much are you strength training? Because if you look at the evidence for knee osteoarthritis, by far the best evidence for long-term outcomes with the least complications is not just the general idea of exercise. It's specifically strength training. So I tell people the older you get and the more arthritis you have, the more important it is for you to strength train. So a postmenopausal osteopenic woman who's in her 70s, that person needs to strength train more than anybody, not less. So I think sometimes there's sort of a society viewpoint or bias about strength training that it's only for young athletes or young athletic males or football players or what have you. But in fact, the people that need strength training the most are the ones that are aging, they're losing muscle mass, they're losing strength, they're losing their balance. Balance training also has excellent evidence for improving outcomes in osteoarthritis. So I think a lot of this just has to do with helping the patient understand that I'm on the same page as them. I want them to return to their activity if we can make it happen. But perhaps the reason they're in my office, or one of the reasons they're in my office, might be due to the fact that they want to do activity X, but they are not physically prepared to do physical activity X. So we have to get you there, and simply playing your sport alone, that might work when you're 12. It doesn't work when you're 62. You can't just go outside and start running and hope that nothing bad happens. So including the strength training, the stretching, the other things that will help make you a more well-rounded and physically prepared person, I think go a long way toward allowing you to do the stuff you want to do. Another analogy I use is, you make your kids eat their vegetables before they can have dessert, right? So doing all your rehab stuff every day, that's your vegetables. If you don't do that, you can't go eat your dessert, which is go play tennis or golf or whatever. But I use that analogy to make people understand, because a lot of my patients are parents, and they understand that their kid would love to have Oreos for dinner. My kids would. Actually, I would too. But we know that the best thing to do is to actually, eat the food that's good for us and make sure we have that. And then occasionally, if we want to splurge on something else, that's fine. But you have to have that foundation in place of the things that are good for us. And so with doing your rehab exercises every day, and physical therapy is a lifelong process. So if you go see one of these ladies here, one of these excellent physical therapists, or anyone else for therapy, once you graduate from physical therapy and you go home, you have to keep that stuff up. Otherwise, the benefits will recede.
What I'm hearing is if you don't use it, you lose it. And it's a simple term, but it really, really applies. A door, if you don't open it, it will rust, and you'll be harder to open that door at the hinges because, non-movement is not good. So the joints are basically a bunch of hinges of the body. And we have to take care of them. We have to keep them well oiled, and we have to support them with the surrounding muscles and the health of that. And then the other aspect of what you said, which I think really needs attention, and for those of you just tuning in, that was Dr. Evan Peck, section of sports medicine, Department of Orthopedic Surgery, Cleveland Clinic, Florida. And we have Lisa Fawcett and Holly Woodford from Saylor Physical Therapy. The idea behind all of this is that there's this internal mechanism that we also need to support the health of our joints. And you mentioned food. Lisa, Holly, Doc? Maybe Lisa, how do you deal with a person who has probably a poor diet, they're transitioning in age, they're leading a healthy life, and they have no concern for what they put in their bodies and how this equates to healthy joint and inflammatory system outlook?
I think a huge part of our job as medical professionals is to educate patients on all aspects of things that affect, in our situation, their performance or their ability to function in both their activities they need to do on a daily basis, as well as return to doing the things they want to do, such as sports participation, but also to act collaboratively. And I think the four of us in this room have done an excellent job of communicating with one another on the benefit of our patients and giving our patients a strong team of individuals to not only educate them on shifts that could make their situation better, giving them the most efficient healing and or regenerative tools to get back to doing what they want to do best.
Right. Key, Holly, diet?
Yeah, no, it's mind-blowing how patients have no clue a lot of the times on protein and basic things that they need. And we, give them the tips, during the treatments, but if they need extra care, we'll definitely refer to our, people that we trust to get them, yes, especially you, just get them what they need.
Yeah. Doc?
I think that, obviously I echo what these ladies have said, but one of the things that I find that patients often are not aware of is the role of healthy fats. Healthy fats are important for cardiovascular health and a number of different health parameters, but also may have some impact on joint health and function. So understanding that, not all fats are bad for you, right, that there are good fats, from fish, from avocado, et cetera, and helping people understand that their diet should include good protein, good carbohydrates, good fats. None of those macronutrients are the devil. It's not zero carb. It's not zero fat. All those things, there's good and bad in each of them, and helping people make better choices is really key.
Beautiful. And I want to just focus on one thing as well. In my position, inflammation can be helpful. However, chronic inflammation obviously is not so helpful. So when you have acupuncture, you're actually restoring the inflammatory process of the body and utilizing it to get the proper amount of blood flow to the area, white blood cells, and all of this for repair. So you can really target joint systems with acupuncture really well to help enhance and speed up that repair. And so sometimes initially you think, well, I don't want to inflame, and so I take these, anti-inflammatories. But what you're doing in the long term is preventing the healing. So we really want to. I think if anyone could take away from this show is that the focus going forward, not only with our knees, because it's the knee show, but with the body, is that let's focus on the root problems. Let's talk about healing rather than just pain.
I agree wholeheartedly. Non-steroidal anti-inflammatory drugs like ibuprofen and naproxen have been shown to slow down recovery after an acute injury. So I always tell patients to avoid those right after they get hurt.
Yes. Well, again, thank you, Dr. Evan Peck, Section of Sports Medicine, Department of Orthopedic Surgery, Cleveland Clinic, Florida. We had Lisa Fawcett. We also have Holly Whitford, both from Saylor Physical Therapy. You can depend on these individuals. They're going to do a great job. And if you're out of state, well, they're definitely worth the flight in. So thank you for joining us. This has been another Maximum Health, Quality Living with yours truly, Dr. Ken Gray, holistic physician. Any questions or comments? That's Dr. Ken at Dr. Ken Gray. That's GREY.com. See you next time.
But it's alright.